spasticity. So we'll come back to those numbers later. So the plan, as I was saying before, is to cover the issues around spasticity and contracture. And we're going to go through some definitions to help clarify the various definitions within this, to be able to better know what we're talking about when we're having discussions amongst ourselves and when we're discussing these things with medical staff as well, who want to make decisions around whether to use botulinum toxin, particularly in terms of an intervention. So stiffness, contracture, talk about tone and try to come down to some understanding of what it might mean. Go on to spasticity, talk about the definitions, talk about measurement, the evidence of its effect on function after stroke, and then talk briefly around the intervention for spasticity, which is primarily at the moment botulinum toxin, and then go on to talk about the evidence in relationship to that. And then the next section will be around contracture, looking at immobilizations and the assumptions around that, and then go on to talk about human randomized controlled trials, and then think about where we might go from there. So some key messages, and to remember, once again, this is my reading of the literature, so that little caveat around evidence is very much beware of experts, and so go and read the literature for yourselves if you're not convinced of the information. The few numbers of studies that have looked at the relationship between spasticity and function have found that there is no relationship with spasticity and function. In other words, people can have high levels of spasticity, measured spasticity, and be able to function well, and the reverse is the case as well. So there's no relationship between the two. So spasticity seems to be like a parallel universe, if you like, in terms of motor function. People can have spasticity and be able to function versus not. And the problem primarily is the ability to turn the muscles on in a meaningful way. There is robust evidence now that stretch interventions do not prevent or reverse contractures. And this is difficult information to digest. As I was saying yesterday, we need to think about the evidence and then think about what it really means for us. But if we're thinking about force production after stroke, there are many things that may influence whether somebody can turn their muscles on or not. And there are two broad categories of problems. One is the negative features, and that is the loss of something. So it could be the loss of strength, which is quite common, particularly in the upper limb, but also lower limb, obviously. The loss of sensation. So people can't feel. They may be able to use their muscle quite well, but may not be able to feel what they're doing, and that can have major problems in terms of being able to functionally use your hand. And how do we go about training that loss of function? On the other hand, there are quite a number of positive features that may become apparent after an upper motor neuron lesion. And this might be hyperreflexias, hyperreflexia that's often seen, some dystonias and so on. And in fact, Burke is an Australian neurologist who wrote an interesting chapter many, many years ago, 1988, as part of his plea for neurologists to be more concerned about the negative features after stroke and not be so preoccupied with the positive features, which is what they tend to use for diagnostic reasons, understandably, to try to understand the expressions. Is there some sort of central problem, and do these positive features give them that ability to make a diagnosis, for example? But the problem for the person is their loss of strength, loss of sensation, loss of abilities to do the things they want to do. And there are many reasons after a stroke, and even in normal muscle behavior, that we will use excessive muscles. So one of those issues might be that there's actually a peripheral change in the abilities of the muscles to lengthen or shorten. So you may get stiffness in the tissue, and we'll talk about this in more detail as to what it means. But basically, what this means is the tissue is no longer as easily extensible as it was previously. You can get to end of range, but it's more difficult for the tissue to stretch. It has a greater resistance to lengthening. You may have contracture, in which case not only might have concomitant stiffness, but you can't get to end of range. And so your elbow as in this example, you can't straighten your elbow, you get part of the way. And we can measure both of those things. We can measure stiffness and contracture. But you may also have, and we saw this yesterday in the afternoon with Tommy, for example, where he's trying to use his hand and he's trying to use his thumb, but he's also using other muscles to try to help contribute to get his thumb abductors to work or his wrist extensors to work. When he's trying to extend his wrist, his finger flexors work at the same time, and his brain is finding it difficult to be able to distinguish the motor planning to be able to do those things. And so if you can preferentially use one muscle that's available to you easily, then that's the muscle you will turn on, and you may then finish up not being able to use other muscles. And so these compensatory strategies can also lead to excessive force production in particular muscles, which then makes it difficult to use others. And then on top of that, we all have a problem when we're learning a new motor skill that they're characterized by excessive muscle activity. And so you get this inability to use your muscles in a really coordinated way. And until you become skilled at that particular task, your motor planning isn't as efficient as it could be. And a very good example of that would be around throwing a ball, where even an adult who is a novice at throwing a ball will look quite disorganized, as a child will when they're trying to learn to throw a ball, that their arms and legs go in all sorts of direction. It's disorganized. The ball doesn't go accurately to the target, and so on. Whereas if you watch a highly skilled person that's practiced throwing a ball for thousands of repetitions, it looks effortless. The ball goes exactly where they intend it to go, and it doesn't look as if there's any effort at all. And so early skill acquisition is characterized by not using your muscles efficiently until your brain learns how to do that. And then I put spasticity last because I'm not convinced that that's a problem that we really need to be focusing on in relationship to motor function. So now onto those definitions. So stiffness. Stiffness is the extent to which an object or tissue resists deformation in response to an applied force. And everything around us has a stiffness quotient. Even this little black plastic pointer box here, it has a stiffness. If I apply a force to it, I can measure the stiffness of this object before it breaks. And in an important study by Natasha Lannon many years ago now, she was interested in the extensibility, primarily in terms of contracture, but also stiffness of the tissues of the forearm when measuring as a result of applying a splint to the forearm. And to be able to do this reliably, she needed to be able to apply a known force across the wrist joint and then measure the angle that you got to. So at the beginning and the end of the study, the same force was applied to make sure that the measurement of the joint angle was the same in terms of the force applied. And then if there's any change in the stiffness of the tissue or the contracture in the tissue, she could be able to measure that. So we have a consistent force being applied, a measured range of motion as a result of that force of application, and then you can measure that angle. So in terms of tissue and measuring stiffness, we can apply an increasing amount of force and then measure the range of motion at each of those points along the way relative to the force applied. And in normal tissue, we get a curve that looks something like this. And so you have very little resistance with minimal force being applied until you start getting towards the end of the range of motion. And in most of us, when you get to the end of range of motion, you still have a way to go in terms of the tissue across that joint. In animal studies, they actually surgically remove the muscles and measure the stiffness or the extensibility of that tissue, and they can go right to that end point. But if somebody has stiffness in their tissues, then you will get a change and you will get a response in terms of the force you need to apply increased amounts of force to get to the same relative range of motion. And so you may get to the end of range eventually, but you get there by applying more force to get to that end point. And so we have this, and you've all seen it and you've all felt it in terms of people that you see, is that you stretch their arm is held in this flex position for most of the day, and then you try to stretch their elbow joint out as one example, and it's difficult to get to end of range, but you can get there, but you need to apply more force. So that's a stiff muscle. Now, if you have contracture, you may have stiffness as well in that tissue, but you may not. It's not necessary that you will have both together, but you get a loss of range of motion. So you can't get to end of range. And so that may be for changes in the soft tissue itself. It may be changes around the joint and so on. So there's various reasons as to why you may have a contracture. Now, there's a vexed question around tone. In one of the fairly recent books about muscles and tissue and measurement, they describe tone as being one of the most commonly used and least commonly defined notions in studies of movement, posture, and movement disorders. So they're really saying that there's no clear definition of what tone actually means. And the problem with that is the lack of a clear and unambiguous definition has resulted in much misunderstanding. And for those of you that are interested in this area, I'd recommend that you have a look at this paper, because it is worthwhile reading to get their take on this issue. And there's a number of factors involved. And Bernstein, who is a Russian researcher looking at motor control, and he came up with this idea about degrees of freedom and motor control. One of the issues around muscle preparedness to contract is that we change our preparedness in anticipation of how much force is going to be required to perform a task. And one of the examples you could perhaps think about is if you're carrying a heavy box and you can't see your feet and you're going up a set of stairs and you think there's another step that you're going to step onto, but in fact there isn't another step. So the foot that steps down on this anticipated next step doesn't hit the next step, but lands on the same step as you're already standing on. And so what you've done is you've prepared your muscles to be able to propel you up another step, but in fact, you just stamp heavily on the ground. So what we've done is we've prepared our muscles to generate more force than we need to be able to step up onto the next step. But in fact, it's unnecessary. So we feel a bit stupid because we've done something that's inappropriate. Sometimes if you go to pick something up that you anticipate that it's much heavier than it actually is, and you pick it up and you lift it higher than you need to, because basically you anticipated that object was going to be heavier than it actually is. So we actually prepare our muscles to generate force relative to what we think the force we think we're going to need. So this will influence the tone that's in our muscles. It will influence um, the force potential of our muscles. So this will change. The other side of the question is that this ability to relax. And so if you took everyone in your gym at the moment and had them lie on a plinth and then asked them to completely relax and then move their heads around, you would find that each person would have a different response to that question. Some people would allow their heads to be moved around effortlessly in all sorts of directions, and other people don't allow that to happen at all. In other words, they do not like not having control over where their head is going. Now, it's not tone, it's just the fact that that person doesn't allow their head to be moved by somebody else easily and effortlessly. So our abilities to lessen the amount of force in our muscles is also individual. Now, this may be described as tone, but once again, it's an individual response to a situation. So we have this difference between the neural capacities, and that is, for example, the ability to relax or the ability to prepare your muscle to generate force, versus the peripheral properties of the muscle itself and the tissue of how extensible it is. And these can get confused together. So then it leads on to the question is, if we can't measure it and we don't quite know what it is because there's no clear definition, then it's probably not a helpful description of somebody's muscle activity. We can measure stiffness, we can measure contracture, we can measure the potential of somebody to generate force. We can measure those things, but tone in and of itself is not a helpful description for a number of reasons. One is the mechanisms of muscle tone and its changes is basically unknown, but it is observable. And the most common method of measurement is subjective. So my suggestion is that we just cease using that as a term, and particularly for stroke survivors. Because if we don't really know what we're describing, so somehow the limb feels different, and we can't measure it because we don't have any clear definition, then it really isn't helpful to tell somebody that you have high tone or you have low tone, because what's that person that's being told that going to do about it? They have no strategies, and we have no way of measuring whether in fact they're different. And so it's important for us to talk to people after a stroke about the things that they can do something about and not the things that they can't do something about. So I would strongly advocate to cease using the term tone and start using the terms like stiffness, contracture, and so on, where we can measure force production, strength. We can measure those things and we can see whether they're different over time. So this then leads on to spasticity. Now, the definition that's accepted generally is this one, and it's attributed to Lance, who once again was an Australian neurologist, but it was actually formulated with a group of neurologists, international neurologists, at a conference, getting together to come up with a commonly agreed definition about what spasticity was. It's a motor disorder characterized by a velocity-dependent increase, so this is important, the velocity-dependent increase, in tonic stretch reflexes with exaggerated tendon jerks, so this hyperexcitability, resulting from hyperexcitability of the stretch reflex as one component of the motor neuron system. So it's really describing a response of a muscle, a peripheral response to a muscle in relationship to the velocity of the imposed stretch. So, for example, if you stretch the limb slowly, the muscle doesn't respond. But if you stretch the limb quickly, you may get this catch, which then subsides. That's the classic definition of spasticity. And here is an example of somebody with spasticity. So initially the person stretches the limb slowly. They do a cursory measurement of range of motion at the elbow. And then there's a gradually increasing velocity applied across the elbow, and there's the catch. So quickly stretch, and a catch happens at the same point. The muscle is responding to this imposed stretch, and you can choose to measure the angle that occurs at if you wish, but that's the classic definition of spasticity, that this person doesn't have stiffness, they don't have a contracture, but they do have spasticity. So just watch that once again. So slightly faster. Now faster again. And then there's the catch. So that's the classic definition of spasticity. The problem is, and as we've seen in that issue of negative and positive features, there are a number of things that occur after an upper motor neuron lesion, one of which may be spasticity, and there's other features as well. So people have been a little bit frustrated by that definition because it doesn't seem to include some of the other issues that do occur after a stroke. And so there's a proposed alternative definition: disordered sensory motor control, so some problem with the sensory motor system resulting from an upper motor neuron lesion, presenting as intermittent or sustained involuntary activation of muscles. So now we have something that might happen intermittently, it might happen all the time, and people don't intend to do it themselves. So now we have a definition which no longer has a clear way of measurement into which we can put any slightly weird thing that happens after a stroke into this definition. And in my opinion, this is not helpful clinically, because now we can actually put anything that we don't quite understand, as long as it happens intermittently or it happens all the time and the person doesn't intend to do it, we can call it spasticity. So clinically, this to me is the equivalent of having a basket of fruit. Now we know that fruit is fruit and it's generally sweet, and you have bananas and apples and oranges and pomegranates and mangoes and watermelons and a whole range of other things. And we can all describe them as fruit as a definition. But each one of those, banana or orange or apple or watermelon, has quite a distinct definition that we can describe that is in and of itself an entity. This definition is like a basket of fruit, unlike the other definition, which gives us quite a clear measurable feature that may occur after a stroke. So what I would suggest is that if people do see these other features, then they need to be clearly defined and have their own characteristics that can be measured, and then we can start to measure each of these things in turn. So it's unclear and it's not particularly clinically useful. Now, Pandian has gone on to produce a book with other authors about spasticity, which I would recommend that you have a read of, because this is their take on this. But my view is that this isn't helpful clinically for people after a stroke. So using that first definition, spastic muscles are electrically silent. So if somebody's lying in a bed, there's no EMG activity in the muscle, and this response of the muscle is purely because of an imposed stretch. And there's a number of models around why this might occur, but Gracie's is a researcher in this area. And I find this model of development of spasticity helpful, because spasticity immediately after stroke is very rare. It's usually something that evolves with time. So you have immediate consequences and you have delayed consequences. The immediate consequences might be paralysis of muscles. That may lead to immobilization in shortened positions. That may lead to contracture. And that may, and there's some suggestions from some research, but that may potentiate spasticity. On the other hand, these delayed consequences, our spinal cord is no longer getting these inputs, or it's getting confused inputs from our brain. And so it starts to become more reactive in relationship to stretch and the things that it responds to peripherally, which may lead to spasticity. And then in some people, you may get that awful kind of reverberating circuit where you do get these terrible contractures of the hand. They can't open their hands to be able to clean them, and their fingernails kind of screw into their hands, and all of those terrible things that do happen. But it's not a common feature after a stroke, but it may happen. So now we have this issue of central versus peripheral response. So to measure spasticity truly, we need to have some form of EMG measurement to be able to separate out the neural versus the mechanical properties of the muscle. And so most researchers don't do EMG studies for measuring spasticity because it's difficult to do, it's difficult to get reliable measures. And the accepted measurement tool to be used for spasticity is the modified Ashworth scale, certainly here in Australia. And the problem with the modified Ashworth scale is it doesn't distinguish between the mechanical and the neural properties. And so it's not really a clear measurement of spasticity. The Tardieu scale, on the other hand, does include an objective velocity component. And so it is better able to tease out this difference between the neural or the mental, the brain component in terms of the change in muscle response to the mechanical properties, that is the peripheral responses. And in a small study by Ada and Patrick, they looked at comparing the Tardieu scale versus the Ashworth scale in people that do have spasticity, and found that in fact the Ashworth scale is confounded by this inability to distinguish between the neural and mechanical properties. So if you're going to measure spasticity, the Tardieu scale is probably a better method of measuring. Now, in terms of the studies, and there's not many studies that have looked at this clearly to be able to, in terms of broad population research, there's only some small studies that have looked at this. But in the upper limb, once again, O'Dwyer, Ada, and Nielsen, and there's a Boatholz trial, which we'll come back to, talking about botulinum toxin and spasticity. But in that study, there seems to be no relationship between spasticity and function. In the lower limb, there's a number of studies, once again, Ada et al. In stroke, but also Fiazi in 30 stroke survivors. And in Melbourne, Gavin Williams looked at people in the traumatic brain injury population. It's 93 traumatic brain injury survivors. So it's a reasonably large study. No relationship between spasticity and function, but a very strong relationship between strength and function. That is, if people are weak, they can't stand and walk. If they're strong enough, they can. And so this, providing they have the skill to walk. And so there's a strong message here for me, which is a very positive one for physios and OTs, that in fact we can work on the things that can influence people's abilities to generate force to be able to move, and spasticity in and of itself is not the problem. So we can start addressing specifically, can Tommy turn on his thumb abductors? Can he begin to learn how to turn on his thumb abductors without his fingers flexing? Can he turn his thumb abductors on while he's trying to maintain wrist extension and start to cycle through that idea rather than be preoccupied with, oh, Tommy's got spasticity, which he may have, but certainly didn't measure that yesterday. So here's the person that we just saw who has spasticity, and this is them voluntarily moving their arm. So they can actually move their arm quite easily. It's a shame that they then didn't go on to look at this person using their arm, reaching for an object, perhaps even doing something fast like punching a punching bag or throwing a ball or something to see what the influence might have been if they're doing something very quickly, and does that influence their function? If we're looking at prevalence, I've added a new systematic review at the bottom of this table, which isn't in your manuals, but you can look that paper up. But basically, initially, when I asked you about what you thought the prevalence of spasticity is, you can see that it's all over the place. We have this early and not particularly well-controlled trial by Watkins et al. That looked at 38% prevalence, down to Lundstrom, who found a reasonably large population of people, 140, 12 months after their stroke, so that period of time for spasticity to develop if it was going to, 4% with disabling upper limb spasticity, and 17% comparing the upper limbs and the lower limbs. And hence we have this systematic review which then looks at the prevalence and risk factors. It's a little bit of a confused review, but it does find this very broad spectrum in terms of the incidence and prevalence. So you were all correct, except for those that said 50% is not nearly as high as that. And if, in fact, it's true that there's no relationship between spasticity and function, then we can just really be preoccupied with the things that we can do something about. If we then go on and look at prevalence in terms of what's being specified, if we now start to move from there to botulinum toxin as an intervention for spasticity, the message here is interesting too for us, and I think we have a strong role to play in decisions around whether people do get botulinum toxin or not. I think this is an area where we can actually have an informed decision with doctors to be able to say yes or no. And I would strongly advocate that we as a profession, in terms of movement scientists, that we are probably in a better position to be able to make this decision rather than doctors. Botulinum toxin is a neurotoxic protein produced by a bacterium, Clostridium botulinum toxin, and in sufficient doses kills you. So it's an interesting intervention that people choose to use. And basically it works by stopping the release of acetylcholine from the neuron to the motor end plate. So the nerve no longer communicates with the muscle. It doesn't change the input of the nerve. It merely changes the communication of the nerve with the muscle. So that the muscle is unable to contract for a period of time, and then it begins to contract again when that ability of the nerve to communicate is re-established. So, for example, my father lost the key to his letterbox some months ago, and so he couldn't get access to his letters in his letterbox until he found the key to open his letterbox up. So the postman is still posting the letters into the letterbox, but you can't get the letters out. So that's the same situation as botulinum toxin. Then you find the key and you can get the letters out, and so you start communicating again. And it's used for many different things. It's torticollis, blinking, sweating, squinting, problems with the vocal cords, and so on. And the issue for these people that have these particular problems is that they go back for repeat injections when their symptoms start to uh, arise again. So it doesn't fix the problem, but it certainly makes these people's lives much more uh, livable than without the botulinum toxin. So it's a symptom suppressant. And as functionally, it's a very good thing for people to use if that's the problem that they have. Now, there's an interesting study, once again, by Natasha Lannon, looking at the effect of additional rehabilitation after botulinum toxin. And the question here was, does the classic recommended program of high intensity training after somebody gets botulinum toxin, does that improve their function versus just getting botulinum toxin alone? So in this randomized controlled trial, there was 140 people that were more than 3 months post-stroke, and they were attending a spasticity clinic specifically for botulinum toxin injection to their muscles. And any of the muscles across the wrist, they had no cognitive impairments, and it was a multi-center trial. So it's across a number of different hospitals across Australia. And there's only 2 people that were lost to follow up. So it's a really complete trial in the sense of following through on a population of people. The control group received botulinum toxin A plus a handout describing stretches that they needed to do for their arms and their hands, and 1 follow-up phone call. The intervention group received botulinum toxin A and then an evidence-based movement training program for 3 months. And they got everything. So they got, if they needed serial casting, they got serial casting. They received 10 weeks of individualized training, electrical stimulation, progressive resistance exercises, with the aim of improving active limb movement 60 minutes a day, including clinical sessions, home visits, and follow-up phone calls to make sure that everything is going okay. Both groups kept a training log, so we have an idea about the dosage of practice. Measurement was primarily the goal attainment scale and also the box and block. There's various secondary measures. Secondary measures really are just seeking out, are there any other changes or differences between the groups? But being a secondary measure, they're not the primary measure of interest. So this is where the outcomes become important. On the goal attainment scale, there is no difference between the groups. So there's a mean difference of 2 with a 95% confidence interval from -2 to 7. So what this means is that it crosses 0. So some people got worse, some people got better. And the fact that it crosses 0 means it's not statistically significant. Box and block, no difference between the groups. However, the important thing in this group of people, because they were coming to a spasticity clinic, they had minimal muscle activity. And so across the board in both groups, most people were unable to actually pick up a block at all to actually begin to show any change. No difference between the groups on any measure in the secondary measures. So stroke survivors with little or no movement of their hand or wrist, additional evidence-based interventions to botulinum toxin A injections were not found to improve upper limb activity compared to non-specific exercises. And the activity logs indicated that the control group had almost the same amount of intervention as the intervention group in terms of choosing to do their stretches and so on. Routine casting and intensive interventions after botulinum toxin in people with no movement does not improve upper limb activity. And perhaps this isn't surprising, because the important thing for these people is that they can actually generate force to be able to then begin to use their limbs again. And if they don't have that motor plan and capacity to turn their muscles on, then giving them botulinum toxin is unlikely to change their brains, because it's also a peripheral input. So we've got to be a little bit careful. We talked a little bit earlier about experts and making recommendations. So these intensive interventions after botulinum toxin were thought to be of great benefit. However, they've been found not to be of great benefit. So consensus-based recommendations for interventions after botulinum toxin for wrist and hand are not supported. So it's only by doing high quality trials that control for all of those variables that we can then start to really understand whether in fact providing really intensive training after botulinum toxin is of benefit. So it's possible for somebody, for example, that does have some muscle activity to use their hand. It might be possible in those individual cases, but across a population of people that are attending a spasticity clinic, providing all that additional intervention has been shown not to be of benefit. Here's an important systematic review, and I would really recommend that you read this if this is an area of interest for you clinically. In the Archives of Physical Medicine and Rehabilitation, systematic review looking at the effectiveness of botulinum toxin treatment of upper limb spasticity post-stroke over different ICF domains. They reviewed the literature up until May the 16th, so this is the first complete review of the use of botulinum toxin in this population. And this is after some 25, 30 years of research. Randomized controlled trials comparing upper limb botulinum toxin injections with a controlled intervention of some sort. So it's either a placebo injection, some sort of control intervention, or some comparison or no intervention at all in patients with a history of stroke. So they came up with 1,212 unique research papers, and out of those they identified 40 trials and 2,718 patients with a history of stroke. The results were, and these are quite clear results, there is robust evidence for botulinum toxin to reduce resistance in passive movement at the wrist. So in other words, if you want to be able to get people to once again passively move their wrist into extension and be able to help open their fingers up so they can clean their hands again, this is a good thing to do. There's robust evidence to support its use in that case. However, and this supports Natasha Lannon's paper as well, robust evidence for the absence of effect on arm and hand capacity, that is the ability to use the hand at follow-up. It's unusual to have a systematic review that is so strong in terms of its recommendations. No further trials are needed to investigate botulinum toxin for its favorable effects on resistance to passive movement. And that's primarily around the wrist, but it may also have the same results. It's likely to have the same results around other joints. The use of botulinum toxin for the clinical goals of improving passive joint motion and improving the ability to care for the affected hand has been validated. Good thing to do. No further trials are needed to confirm the lack of effects of botulinum toxin on arm and hand capacity. That's once again a very strong recommendation from a systematic review. Interestingly, they also comment that the underlying mechanism of how botulinum toxin affects the resistance to passive movement remains unclear. So why is it that if you apply an injection to the motor end plate, which stops the nerve from communicating with the muscle, why does the muscle, the tissue of interest, then become less stiff? And that's still unknown about what the actual mechanism of that is. So we're going to look at a number of these sort of forest plots over the next few days. And so in this forest plot here, we have spasticity-related pain, involuntary movements, and then passive joint motion. So we can see that if what they've done here is combine these papers together to get an overview of what they mean. These little diamonds here, the mean point, the middle of the diamond here, those pointy bits are the mean of that particular group. And then the tails on either side is the variability of the population. How much does this population respond to the intervention? And if those pointy bits cross zero, like in this example, for example, then in fact what it means is they're not statistically significant. So you want the whole population to change in that direction. So then you can say, yes, this is an intervention that is of benefit to that population. So spasticity-related pain, the overview is positive. The overall outcome is positive. And for passive joint motion, it's quite clear overall that there is a positive benefit to improve range of motion. Arm and hand use, this is over a reasonably large population of people. It's quite clear in all of these studies, it's not just one or two studies, but every single one, there is no difference in outcomes. And this is very disappointing, not only for the stroke survivors themselves, but also the clinicians working in this area, that botulinum toxin doesn't make a difference. And it's not hard to understand because the mechanism of botulinum toxin is peripheral. It's not actually changing somebody's brain. So now leading on to the botulinum toxin trial, looking at upper limb in the more acute phase. So this is a paper in Stroke, and you can download this paper for free. In this trial, botulinum toxin and 1 month of evidence-based practice therapy versus evidence-based practice therapy alone. Botulinum toxin was possible at 3, 6, and 9 months. There's 333 people, so it's a large trial, very expensive to run across multiple sites in Europe. People had spasticity, they had decreased upper limb activity, and there was enough power to detect a 15% difference between the groups. The primary measure was the Action Research Arm test at 1 month with multiple secondary measures. The outcome was that there's no difference between the groups on that primary measure. Their conclusions were that botulinum toxin is unlikely to be useful for improving upper limb function, and that was confirmed in that systematic review of Andringes. May improve hand hygiene, facilitation of dressing and pain, so once again, the ability to open the hand. And then goes on to conclude that supports the argument that spasticity is of less importance. This is in relationship to recovery of function. So remember now, these are my overall conclusions. If you're uncertain about the evidence, please go and read it for yourselves. Spasticity is not correlated with functional abilities. Contracture may potentiate spasticity, so if we can have some influence over the development of contractures, that may help. Botulinum toxin may decrease pain in some individuals, but not across a population. Can improve passive joint motion to care for the affected arm and hand. Does not improve active upper limb function.